Welcome back to the MPRINT Hub, where we talk about maternal and pediatric pharmacology. Today, we're talking about how real-world health data can be used to better study medication use and outcomes in pregnancy and childhood. We are joined by Dr. Colin Rogerson, who is going to walk us through how his team links electronic health records of mothers and their children across health systems. Why does that kind of linkage matter for research, and how does it open the door to answering important questions about drug safety and long-term outcomes in maternal and pediatric populations? Dr. Rogerson.
Hello, everyone. My name is Colin Rogerson. I'm a pediatric critical care physician at Riley Children's Hospital. I'm a Regenstrief Investigator, and I'm part of the MPRINT Real-World Evidence Core. And I'm going to be talking about some of the work that the Real-World Evidence Core is doing for MPRINT and what we have done, and how it can potentially enhance the observational research that we can do in the area of pediatric and maternal pharmacotherapeutics. So a little bit about the Real-World Evidence Core. Again, we are one of the cores of MPRINT. Our focus is on using real-world evidence collected in electronic health record systems for observational research. As many of you know, women, infants, and children are on under-researched populations because of their vulnerability. And so a nice way to do research in these populations is using observational studies, observational data that's already been collected in the routine process of care. But there are some limitations to this that I'll go into, as well as some of the ways that we're working to overcome this. So the Real-World Evidence Core is focused on leveraging data from EHR systems to enhance the study of maternal and pediatric health, pharmacotherapy, and precision medicine. Here are some profile pictures of the members of the Real-World Evidence Core. So we have members from 3 institutions. So on the left side is myself and Dr. Sean Granis, who is a Regenstrief investigator who has expertise in healthcare record matching. In the middle is Chris Bartlett, who's from Ohio State University and Nationwide Children's Hospital, who's a data scientist and part of the MPRINT works with Dr. Lang Lee. Next to him on the right is Dr. Anea de Mendonça, who is from Children's Hospital of Cincinnati, who is an expert in natural language processing and informatics. And on the far right is our project manager, Medina. So the goal of the Real-World Evidence Core is to provide MPRINT with a large, robust, secure, and accessible data set for maternal child research. Again, we represent 3 institutions: Indiana University, Nationwide Children's Hospital, and Ohio State, and Cincinnati Children's Hospital Medical Center. And the goal of MPRINT, or the Real-World Evidence Core of MPRINT, is to combine electronic health record data from all 3 of these systems into one large, diverse, and robust data set that can be used for maternal child research. So what would be in this large data set? Again, we'd have data from 3 different institutions. We're geographically similar, but our practices are diverse in some ways. So what is standardly recorded and captured would be from each institution, the structured data elements that are common to most electronic healthcare record systems. So things like demographics, diagnostic codes, laboratory values, medications, vital signs, and procedures. Again, we would capture these in standard data formats across all 3 sites and put them together. This is actually kind of the easiest part of the project. The harder part, and what I'm going to talk more about today, is the data enhancements, things that are not routinely captured in many or all electronic healthcare record systems would be very productive and helpful for research to have these things captured in them. Very beneficial to the research. So we've worked on both the maternal child linkage and the pregnancy phenotype. Today, I'm not going to be talking much about the pregnancy phenotype. I'm going to be focusing more on the maternal child linkage. So to give a little bit of background on what this means. So those of you who are clinicians will have a pretty good sense of this already, but you can have a single individual who in one healthcare record or in one health system has all their records captured really well. It has all their demographics, their vital signs, their diagnostic codes, procedures, everything like that. However, that individual doesn't have to go to the same hospital over and over again. They can go to different hospitals, and then many individuals go to multiple different hospitals, and each hospital system will make a different record for the same person and put in the data that they collect during their hospitalization or hospital visits. So one of the challenges is if we are looking at a more high level view, like from a city or statewide perspective, how do we know if that person is the same person when there's three or four different records for them? So the goal is for patient matching is to look at things like name and date of birth and address and see if we can say that this record is actually the same person as this other record and then merge them together. It can be challenging though, because I mentioned things like address, which can change. So they could have come to one hospital and then 3 years later they moved and went to another hospital. So in theory, their name, date of birth, gender won't have changed, but their address might. And so there are a lot of um, studies and a lot of work being done to try and refine this process to do it accurately. So here's again kind of several different publications in this area of trying to link records across systems. Again, these are looking at trying to identify the same person in multiple records, and then you can merge them to say put it all together, and you can kind of follow the person's medical journey. You'll notice that Dr. Sean Granis is an author on all four of these because this is kind of his main area of expertise. So with MPRINT, we come to a little bit different challenge. So yes, we should link records across systems for the same person. That is helpful for MPRINT. It's helpful for all studies using EHR data. MPRINT has a little bit of a unique challenge though, because we would like to know not just is this the same person, but we would like to know if there is a person who is a mother, which records are the children of that mother, and can we link their records to the mother's record? It's a little bit more of a challenge than just is this the same person, but that's what we attempted to do as part of the real-world evidence core of MPRINT. So that was the research question that we started with, is can we reliably identify maternal-child relationships in electronic health records? The goal was to see if we could use the structured EHR data that's captured for all patients in every system, and can we use that to match maternal records to child records? Again, thinking about this practically, their first names will probably be different, but not always. Their last names will probably be the same, but not always. Their addresses will probably be the same, but not always. Their telephone numbers will probably be the same, but not always. And so thinking about it like this, because there are so many exceptions to those rules, we had to make what we call a probabilistic model that will look at each of these elements and say, if the telephone numbers are the same, what is the probability based on the other things that this is a mother and a child? And so it can get pretty complicated. So I'll go over a little bit of a not high level, but medium level detailed explanation of what we did. Again, there's a lot more fine detail and nuance to this, and if you're interested, we're happy to provide more information on that, and I'll provide the journal citation for what we did at the end if you want to read the whole article. But here is a diagram flow sheet of kind of the process that we used to build this algorithm. So we used what's called the Indiana Network for Patient Care, which is a statewide regional health information exchange. And what that means is that we collect healthcare record data from almost all the hospitals in Indiana, and they all share their EHR data with what's called IHIDE, the Indiana Health Information Exchange. And then that data is captured in the INPC. And so this is the data set we use to develop the algorithm. So starting at the far left, we looked in the INPC, and there are 82 million patient records. And so the goal is to try and build a matching algorithm to find all the records that are mothers and all the records that are children of those mothers and then match them. So The first arrow has 9 blocking schemes and business rules. So the business rules are things that had to be true every time, no matter what. And what we chose for the business rules is that the mother's record had to be a female, the child record could be male or female, and that the mother's record needed to be 15 to 55 years older than the child record to try and capture that age and time difference. We understand there's going to be some rare exceptions that fall outside of that age range, but for the vast majority of patients, they'll fall within those. So that helped us kind of rule out a lot of matches that we know are not going to be good matches. The blocking schemes is where we looked at things like telephone address, zip code, last name, and we said you have to match on at least two of three out of the three categories. And the categories were name, address, and phone number. And if you match on two of these, at least two of these, then you can be considered as a potential pair. If you only match on one or you match on zero, then you're so unlikely to be a child record or maternal child pair that we're not going to consider you. So, doing it that way and then looking at all the possible pairs, we ended up with 6.2 billion potential pairs that met the business rules and the blocking schema. So 6.2 billion is a lot. And if you're going to build a phenotype or an algorithm, you need some sort of gold standard so you can actually look and compare. These look like they're matches, but how can we be sure that they actually are matches to train our algorithm? So in one of our health systems, predominantly, there was a maternal child linkage indicator built into the EHR system. So in this specific Epic EHR system, if a baby is born in this health system, there is a linkage that says this is the mom's record, this is the baby's record, 100%. So we used that as our gold standard. And we looked at all the record pairs that had that indicator, and there were 33 million. So we chose the 33 million as our gold standard positives, meaning that these records are 100% maternal child matches. So then we chose an equal number, 33 million pairs that did not have that indicator and chose those as negative controls because statistically, if you just randomly picked two records, even if they met the blocking schemes of the business rules, they are unlikely to be pairs just picking them by random. So we used an equal number of negative controls. So then we developed our model and we used a machine learning model. We tried a few different approaches, but the one that worked best was what's called an XG boosted machine. It is a regression tree model based machine learning model, and it does a really good job of using large volumes of data that is messy and can have some non-independence, can have a lot of non-linearity. It does really well with these types of things. And so it's a common model for a situation like this. So we built our XG boosted machine model to try and predict for two records that met the blocking schema and the business rules, what is the probability that you are actually a maternal child pair? And then we trained it using all of this data, and then we tested it on a small holdout. And we measured the model metrics, so precision, recall, and F measure to get the results. So here is our test data set that we applied the algorithm to after it was trained. So on the left, we have the true label, which is, again, part of that 33 million. Did you actually have a link? And then the predicted label is, did the model predicted that you were linked together? And so looking at the confusion matrix here, you can see 8.7 million had the true label and were predicted to be pairs. 9.8 million didn't have the link and were predicted not to be pairs. And then we have the mismatches in the other corners. So top right, they had a true label, but were predicted not to be pairs. And the bottom left, they didn't have the true label, but were predicted to be pairs. So doing the math on these numbers, at the bottom, we have our final metric. So accuracy was 92%. So if you look at all predictions across the board, 92% of them were correct. Precision is 98%. So precision is another term for positive predictive value. So if a record was labeled by the algorithm as being a true pair, there was a 98% chance that it was in fact a true pair. Recall is another term for sensitivity. So out of all the true pairs, how many true pairs are identified by the model, by the algorithm? 87%. Then F1 score is a mathematical calculation where you put all of those metrics together and it gives you an overall score, which is 92%. Overall, looking at these are pretty high metrics, especially for something like this where there's a lot of gray area. Again, where addresses, phone numbers, telephone number, or first name, last name, like they are probably going to be shared in some way, but not always. So for a messy data set like this and kind of a grayish application, these are really good metrics. We also wanted to make sure that there's always a give and take between precision and recall because you can make the probability, you can adjust the threshold. So you can say, it needs to be above 50% probability, and then we'll give it a 1. And if it's less than 50%, it'll be a 0. You can always adjust that depending on what you want. So if we want a really high precision, meaning we want to make sure that if the model predicts a link, that we're very confident that that is a true link, then we can move the threshold up, right? We can say, well, it's got to be 60, 70, 80% chance. The downside is that you'll lose recall or sensitivity, meaning there will be links that are true links that you don't find. And if you want to be really sensitive, you could move it the other direction. So in our use case, we're going to assign a label and use it for observational research. While we don't want to miss patients, it's worse probably to predict a link that's not actually a link. And then you're, in theory, using a lot of records from mothers that aren't actually the mothers of the records that we think they are. And that will add a lot of bias to the studies. And so we wanted to emphasize high precision, which is what we got here at 98%. So this is very, very good. We're very happy with how the results turned out. And here are the curves. On the left side is the precision recall curve. On the right is the area under the receiver operator curve. Again, area under the precision recall curve is 0.96, and area under the receiver operator curve is 0.97. So very, very good all around. This is what's called a variable importance metric graph. And essentially this looks at the variables that were included in the predictive model, and it tells you which were the most important predictors of the outcome. So looking here, what you can see is that the telephone number was pretty far and away the most important variable. If the telephone numbers matched, there was a very high chance that they were maternal-child pairs. If the telephone numbers did not match, there was a high probability they were not maternal-child pairs. Second is street address with the street number only. So if the street address number was the same, very high chance that they were true pairs. If it didn't match, very high chance they were not true pairs. And then there's a big drop off. You get to standardized last name, little drop off to get to zip code, and pretty much everything after zip code had really not a lot of importance in the model. So we built this algorithm as part of MPRINT, and with the good results that we had, we published this in the Journal of the American Informatics Association just this year in October 2025. And for those of you who are not informaticists or informaticians, this is a very good journal in the field of informatics. This is kind of like JAMA, but for informatics. So we're very happy to get it accepted there. Yeah, it was a big deal. We're very excited. So what does this mean for MPRINT and for MPRINT researchers? Again, the goal was not just to get a publication in a good journal. The goal is to be able to use this for practical applications to help forward or progress the field of maternal-child health research, maternal-child pharmacokinetics. So What we can do now is if we have a large database that has reliable matches that says this is a mother and this or these are her children, we can do some observational studies that haven't really been able to be done on a large scale before. So for the first example, we have rare diseases. So questions that you could ask now with this data set and the enhancements made with the maternal-child linkage. Again, do mothers with systemic lupus erythematosus have children at increased risk of juvenile idiopathic arthritis or kidney disease or inflammatory bowel disease? Again, my expertise is not necessarily in maternal child health, and so a lot of these are things that I just thought of and made up, but those who do study this kind of thing specifically will have a lot more practical use cases. But these are questions that we could answer with the enhanced MPRINT database that's coming. Do mothers with endometriosis have children at increased risk of growth problems or developmental delays or cardiac conditions? Again, these are things that probably have been studied before, but they would have been in very small sample sizes, usually from one center or a few. And again, the sample sizes would have been pretty small. Now, in theory, with the MPRINT database, with the enhancements from the Real-World Evidence Core, we could ask these questions and do it on a scale of 3 institutions over a 5 to 15-year time period, and we could have thousands and thousands of patients to look at this. Drug effects, again, big focus of MPRINT is how does maternal medication use affect the children, both at delivery and in the infancy, but also for longer through childhood and into adulthood. So things you could ask, do mothers who take SSRIs during pregnancy have children at high risk for ADHD, at high risk for feeding issues, eczema, or allergies? Do mothers who take antiemetics during pregnancy have children at high risk for lung disease, prematurity, musculoskeletal disorders? Again, these are things that I mostly made up and may not be real things, but these are questions that we could answer with the maternal child linkage indicator and the MPRINT database. So those of you who are interested in doing this type of research, we're very happy to lend our expertise, and we're in the process of, again, still building that large, diverse data set. But because of the maternal child linkage, which we think is fairly accurate, we'll be able to do this type of research with pretty good reliability. Again, the list goes on. There are many other things that we can study, and we are kind of reliant on the pharmacists and the OBGYNs and the other scientists that this is their area of interest, their research expertise, and we'd love to partner with you. So again, the goal right now is to get Indiana University, Cincinnati Children's, and Ohio State nationwide all into the single database with all the HR data and the maternal child matching. We'll also have a pregnancy phenotype, and we're trying to get social determinants of health data in there in a pretty robust way. And then the goal after that will be to continue to expand the data set into the other MPRINT sites like Vanderbilt or Rady and other places like that. So thank you very much. Again, feel free to contact MPRINT investigators and reach out to me or anyone else at the Real Evidence Core if you have questions. And we're happy to share this with you, and thank you for listening.
Thank you so much to Dr. Rogerson for joining us, and to you, our audience, for watching. If there are any other topics you'd love to hear us talk about, let us know in the comments below, and we will see you in the next one.